All righty. So it is 6:01. So let's get started. Again, welcome everyone to the Business of Health Career Networks program, Providers and Healthcare Delivery. Panel tonight, we're so glad that everyone's here. We have some wonderful guests tonight. And this is part of the UNC Center for the Business of Health Career Networks program. Career Networks is a constellation of resources meant to educate and create community around the continuously evolving healthcare ecosystem. You can explore the CBOH Career Networks platform via the URL pasted in the chat box, and I'm pasting that right now for you. For tonight's panel, we ask that you turn your video on and mute your microphone while not asking questions. If you are in clinic or somewhere where you cannot have a camera on, just due to privacy reasons, we understand that, but otherwise we would really like you to have your camera on as this is a conversation and discussion. Tonight's panel will begin with our guests introducing themselves. Then I'll be asking moderated questions. I'll stop every 2 questions for audience questions. When you have a question, please raise your digital hand, and that should be below. There's a little tab, and if you look at reactions, it should be under that little heart. If you have a burning question in between, feel free to raise your hand, and I'll go ahead and call on you when we have a little bit of pause in the conversation. I'm Suzanne Killian. I'm the Associate Director for Student Engagement with the Center for the Business of Health. And I have Erin Leach, our Program Manager, behind the scenes tonight. Tonight we have 3 outstanding panelists with us. We have Shawn, Chase Jones, and Audrey Lysko, or Lysko. You got to correct me. Lysko. I thought it was, and I overcorrected myself, but we're so glad to have them with us. And they will be sharing their career journeys and introduce you to the industries from their diverse perspectives. And you'll see that's what we aim to do with these panels, is to have many different perspectives. So I'm going to let the panelists take it away and introduce themselves. And I am going to go to Chase Jones to go ahead and begin. We could go with Chase, Shawn, and Audrey.
Thanks, Suzanne. I feel like Audrey should lead us off because she's actually dressed in the right colors. Meanwhile, Shawn and I are just blatantly disrespect. But hey, guys, really excited to be here. And again, just to echo Suzanne's comments, hopefully this is as informational, but also much of a discussion as possible. So by all means, interject, raise hands. Please come off camera just so you can give feedback if that's a bad joke that I tell, or if not, if it's good. My name is Chase Jones. I currently work at Thyme. We are a oncology navigation platform that works with oncology patients across the country, partnering with health plans, risk-bearing provider groups, and providers themselves. Prior to that, I worked at City Block Health and DaVita Healthcare as well. But I am a Tar Heel, graduated from Keaton Flagler. Let's go Heels. Some time ago, I'm not going to tell when from an undergrad perspective. Did an MBA at Wharton through the healthcare management program there. And prior to grad school was deeply embedded in the pediatric oncology space. So excited to talk about all things provider care delivery, from anything from peds to where we are now, particularly in the oncology space. But very, very excited to answer any questions that we can along the way. So I will turn it over to who's after me, Suzanne? I think that was Shawn.
Shawn. Yep.
There we go.
Great start, Chase. So I actually didn't think about my colors. I definitely looked at my UNC blue shirts and I was like, I've got like 17 of them. I was like, we don't need to do that. Probably missed the cue. That's whoops. My name is Shawn Hugard. So prior to attending UNC Keaton Flagler, I was in the Army for 8 years as a nurse. So I actually did oncology as well. So I started off as a med-surg peds nurse over in Landstuhl, Germany, which is our major hospital over there. And then I moved over to Walter Reed, where you probably hear about on the news for all the fun stuff. There I ran an inpatient oncology unit. And then I also took over working as kind of a social worker-ish role with our wounded warriors. Graduated in 2024, just took a gap year because I wanted some time off. But I am happy to answer any questions about what nursing looks like and just the differences between the military healthcare system and the civilian healthcare system, as they are black and white.
Cool. I'm actually interested in that as well. My name's Audrey Lysko. I am currently a division president for Unified Women's Healthcare. I've been here about 3.5 years. Prior to that, I spent a little over 10 years in healthcare consulting for the Chartis Group, working with hospitals and health systems. And actually, that was right after graduation with my full-time MBA from UNC. And I am wearing Carolina blue tonight, although I don't even know if I should reveal this. I did go to undergrad at Duke, so sometimes it pains me a little bit to wear my Carolina blue, but I did it for you guys.
My goodness, see, giving already tonight. So you're comfortable with those two shirts up there, so we're all
Yeah.
good. I'm in black, so it's all the colors, kind of, unless there's an artist out there who will correct me. So, or the absence of color. I can never remember which one, but we're so glad that you all are here again too. I really appreciate the fact that you all came through different journeys, different paths, and have different experiences. I am excited to hear about those as well. And so I'm going to ask the first question because I think this will be kind of like a clarification for folks maybe new to the business of health or healthcare in general. So I'd like to know just briefly from each of you, what do you feel that a provider is and what is healthcare delivery in your perspective?
Do you want to go reverse order here?
Sure. What's popcorn?
Sure.
Audrey, why don't you take it
Yeah,
up?
so I think provider is actually a little bit more of a tricky term, I think, because it's used in a lot of different ways, right? Provider can mean a physician. It can mean an advanced practice provider, which is a nurse practitioner, a physician assistant, a nurse midwife, for example. I think it could even be broadened to more members of the clinical care team if you so choose, like psychologists, things of that nature as well. It's not really a clear-cut definition. And also we call hospitals and health systems providers sometimes as more like provider organizations. They're collectively providing care for their communities or for a defined population. But curious to see if my co-panelists have different perspective on that.
So coming from the nursing background, I also agree with you that when I think provider, I'm thinking MD, DO, I'm thinking physician assistant, I'm thinking nurse practitioner. I do also agree that we tend to talk about providers as the whole team. Like I wouldn't think of an RN as a provider. I think of it usually as someone who can write medical orders and prescribe medications, but then there are more parts of the team. And as far as the healthcare delivery system, it's all part of that team because that patient needs all of them. Like doctors are great, they're really smart, but if you ask them to do some of the put an IV in, unless they're an anesthesiologist, they are very confused, they're very lost. They're like, I just want you to give them the med. Like they have no idea how to get the medication. So you do need multiple people in that team to help.
The only thing I would expand on is one, completely agree, Audrey, that the term provider, I remember first hearing it, and it was not probably until after actually graduating undergrad where I had to sit and think, what does that actually mean? And it is super confusing. But I think tangentially in my mind immediately races to everything that's said thus far, but a yes and to the extension of where anybody is actually receiving their care. And I'm saying care in a very broad, loose way. So I immediately am thinking about any of the connected community efforts that somebody might be receiving food as medicine, if it's an SDOH connection, or if somebody is receiving palliative care in the community setting that may be tangential but not offered directly from their direct provider or oncologist or hematologist or who direct provider from a healthcare system. And so I think the definition gets a little bit broader, but maybe the starting place where I try to define it is probably the wrong, very greedy way. But if it has a way to be billed, then it could be considered a provider. And so I think the extension would actually be, in some cases, a caregiver of somebody's family member as well. And so I hate to be even broader than the definitions applied, but the way that I traditionally think about it is that if there is a CPT code that's involved that could be actually billed to the government, then that would qualify as a provider.
It's a good way to look at it. And you said an acronym in there that I wanted to clarify, which is it's an important one. SCOH. I don't know if that's something that this group is familiar with. So you want to go on, expand on that one.
Thanks, Audrey. And I apologize. I am the most stereotypical healthcare guy that just says a bunch of acronyms, and I am so sorry. So please, everybody else, like cut me off and say, what is that? SUH, social determinants of health, also known as social drivers of health. I think both those are really bad definitions of what the actual sentiment is, which is all of the other elements outside of the physical medication that somebody receives could be considered into the elements that somebody's driving overall health. And so you could consider SDOH category to be food, like I mentioned earlier, or something we've done really, really incredible in North Carolina, which is set up programs to assist housing or other elements like getting rid of somebody's bad carpet because it's driving up asthma in their house. All of those are elements that would physically impact somebody, but not necessarily in the direct line of thinking of here's medicine for somebody's issue at hand. I don't know, Audrey, if you got a better one than that,
No.
please do.
You said it beautifully.
That was terrific. And again, to Audrey, thank you. And yes, we will often call back on you to refine your acronyms because there are just so many in healthcare. But that was a wonderful explanation, Chase. Thank you so much. And important for the group to know. My next question, well, first of all, you all did a great job of defining, even though we don't have one definition, I think that this was great for everyone to hear, defining provider or healthcare delivery. And I think it's dynamic and it will change and it'll keep changing. But at least everyone has a perspective of the fact that we do have providers that provide care in so many different ways. I'd like to kind of come in a little bit now and ask you each to define your current role or your latest role and talk a little bit about what steps you took to land in that career and why you chose. And again, we can popcorn around and actually we'll I'm going to hand it over to Shawn this time because let's mix it up.
Man, so the last thing I did is I did try a startup, but that's nothing to do with healthcare. A lot of MBA's level stuff, but I will talk about probably what I did at UHG. So I worked for UHG is a large healthcare, is a large payer in the system in health group. I'm sure you're familiar with them. And I worked for level 2, so they have a whole bunch of startups, and the startup was focused on type 2 diabetes, and essentially they were trying to enhance diabetic outcomes by reducing medication reliance for type 2 diabetes. So if you're familiar with type 2 and type 1 is you're going to need insulin. There's no way around it. Type 2, you're insulin resistant. But with lifestyle changes, you can reduce your need for medications. So weight loss, activity increases, dietary changes, things of that nature. What was the question here? Oh, sorry, I got a little sidetracked going into what level 2 is and forgot where my point's supposed to go with this.
Sure. Just kind of defining your current or most recent role and what steps did you take to land in that career and why did you kind of end up there at this point in time?
Oh yeah, I was super excited for it because I love the idea of reducing medication, right? So a lot of what the current healthcare system is to continue to give more medication. We just keep prescribing meds and these have side effects. So then we prescribe you another medication to counteract the side effect. Where this was working to reduce the overall medication burden a patient has by doing lifestyle changes they could affect health, like, dietary changes, physical fitness changes. So it's a side of healthcare we don't talk about very often that kind of gets like, oh, you should exercise more, but we don't necessarily provide people with the tools to utilize these things.
And again, popcorn around.
Go ahead, Chase.
So I mentioned earlier Thyme Care and what we do. We provide oncology navigation. I got hear from this excitement of being able to apply value-based care in oncology specifically. When I joined 3 years ago, Time Care's a little bit older than that, and my role specifically is being able to go partner with health plans and risk-bearing provider groups and to build some really cool models together. So I would say that the roundabout way of getting here, and maybe some food for thought, just of folks are thinking about their own career development, was that I really, really passionate about the oncology space and value-based care. I love the idea that there's got to be a better way to solve a disease other than just fee-for-service billing on every single element that somebody can have, just to align incentives in a better way. And got to join here at a really exciting time of advancement in oncology and specifically value-based care in oncology, with the government starting to invest in different models that would actually incentivize providers and oncologists specifically to think about how to deliver their care. Man, I'm saying all the buzzwords again. I apologize, guys, but I'm trying to lean in on the provider and healthcare delivery. But joined with the mission of there's got to be a better way to be able to support somebody that's going through their cancer journey from the entire process, not just when they're receiving their oncological treatment, not just when they are getting the diagnosis, not just when they are going to see the admitting doctor because they feel like crap day 3 after chemo and they are going to be nauseated and going to end up in the ED. There had to be a better way to solve this. And that's where we're coming at from Thyme Care perspective. So a long-winded way of saying, Suzanne, of my role specifically now is trying to grow the company in a way that is strategically aligned with health plans across the country and other providers. And excited because thankfully, and I would love to get Audrey's take on this as well, it is, as an industry, starting to turn a bit towards value-based care in specialty specifically. And it's been a great time to be a part of Thyme Care during this journey. So that was a very big plug for Thyme Care, and I apologize, less about my own background, but clearly excited about where we're headed to. And I'll turn it over to Audrey now.
Yeah, I'd love to talk about that topic, but I'll start with me. Going back to graduating from Keenan Flagler, I started out at a healthcare consulting firm called Kurt Salmon, which was, those of you who MBAs will appreciate, it was the only consulting firm I applied for. I was never going to do consulting until I did for 10 plus years. So that's how that turned out. I ended up working about 5 years at Kurt Salmon, and then there was an acquisition and I shifted followed some mentors over to Chartis. Absolutely love Chartis. You'll never hear me say anything but wonderful things about Chartis as a place to work. But after made it to partner, and I just looked around and said, okay, it felt like an inflection point for me. Am I going to double down? Am I going to be a career consultant? Or am I going to take this opportunity to go explore some other avenues of healthcare? Because in that 10 years that I was consulting, healthcare had exploded. And there were so many unique and cool companies, emerging technologies, et cetera, people doing different models of care. And I just felt like I would regret if I didn't do something different than I was doing. And so during that exploratory period, I got a call from a recruiter and just took the call. And it was this opportunity at Unified. And so ended up, one thing led to another, ended up taking this role. So a little bit about Unified. We are a management company for OBGYN practices across the country. We are technically the largest women's healthcare company in the country, but you've probably never heard of us because we are really kind of a behind the scenes B2B type model. So we provide, you guys may or may not know, it's almost impossible to be an individual private practice in any specialty in this current environment. And so we bring groups together into larger groups so that they have collectively more bargaining power. There's kind of strength in numbers when it comes to creating these value-based care contracts, for example, with our payers, and purchasing and all the things that come with numbers. And so we and Unified is a little bit unique from other physician roll-ups. If you may hear, there's physician roll-ups in every specialty. We don't technically employ the physicians; they maintain employees of their medical group, but we just provide management services. So we provide their EHR, we provide HR, we provide accounting, we provide IT, all those things that the practices don't really want to focus on. They want to focus on delivering that clinical care. So we are their partner in allowing them to do that. We are private equity backed, so there's some interesting components to that as well, which we may or may not have time to get into.
Terrific. Thank you. These were great introductions to your current roles, how you got there, and why you're so excited about them. It sounds like everybody really believes in what they do and kind of how you worked your journey to get there. I am going to back up just 1 second to Shawn, because I am curious about the military, about becoming a nurse in the military, and what made you make that decision?
Honestly, I have family of service. I've had a family member in the service going back 3 generations, so it just kind of stuck with me. And that's pretty much what drove me. A little bit of guilt, a little bit of just everyone else. I didn't want to break the chain. As far as the military healthcare system, I don't think I fully realized how different it was from the civilian healthcare system. We don't talk about the fact that it essentially is a socialist healthcare system. Everybody gets care. There's no co-pays. We get you in. It's much faster. It's much more, not about much more efficient at times, but you can definitely get access to things you wouldn't normally. It would take months in the civilian sector. So it's very different being on the outside now and dealing with problems of just access to care is much different. Healthcare plans all look the same. If you go look and you go to choose your healthcare plan from your work provider, and you look through and they're trying to choose the different plan types, because even level 2, technically, what I talked about, it's a healthcare plan, but there is 25 different variations of that plan, and they're so minor and minute. It depends on the cost and things like that. Where TRICARE, everybody had the exact same plan. You had an issue, you'd go get seen by a physician, and we'd get you taken care of.
That's fascinating. Thank you, because I was just very curious for you to add your perspective from that military. I hope that you'll contribute as we talk about more, well, at least as I ask more questions, because I think that that's a fascinating aspect here as well. So I am going to pause for a moment and see if our audience members have any questions that they'd like to ask at this point in time. Hi, Nita, how are you? Go ahead.
Hi, I hope everyone is doing great. Thank you for your time. My question is for Chase, because I mean, I come from India, having led a similar health tech startup for surgical care. One of the challenges we faced when it came to patient-reported health outcomes was that they were either not in a position to report them, or they did not have caregivers around. I just wanted to know how much of a problem it is with Thyme Care, and if we know that we can improve our outcomes only with data, and if the source of the data is the patient and you're burdening them with that job, how do you balance meeting those objectives? Yeah, thank you.
No, it's a great question. 1, thank you for being on camera, Nita. And 2, I've got a 3-year-old and 1-year-old daughter that are coming home right now from dance. And so if you hear things in the background, that is why. Great question. So the ePros, or electronic patient reported outcomes. There you go. There's your acronym explanation, Audrey. Love it. Just to take a step back on the importance of these, there are a number of studies that we look to on a daily basis of what can actually improve somebody's oncological care. And by and far away, electric patient reported outcomes, ePros, are the absolute game changer when it comes to improving both outcomes, quality of life, actually survivorship rates. And it's because somebody's able to in our case, text in or report back what's going on and what are their symptoms. And so somebody can be proactive in an actual management of that their respective cancer journey. What we have come up with in the scenario that you're describing of, if somebody is not able to give those ePros, we have taken and eaten the cost and just delivered iPads to the members that we're responsible for, so that they at least will have the tools to set it up and go in the home and then make sure Wi-Fi is everything is there so that they can report back. That's not an ideal setting that we do that when we have to. Ideally, we can get to either one, we're using somebody's phone, which we've actually found like we've gone to the direction of just using text only, not trying to bring in an app or another mobile form, just going to text basis. It makes it much easier to interact with. Or then secondly, like you mentioned, the caregiver. One of the, I think, critical components of that is when we are engaging and enrolling somebody into our services. And so the process looks a bit like we get sent by a health plan or a risk-bearing provider group. Here's a chunk of patients that we're responsible for. We go out and then call and engage and enroll folks to be a part of Thyme Care services. But there's a critical step in between there, which is in the actual like identification and calling of folks and saying, hey, we're Thyme Care, we're this awesome service. We do take the step to make sure we're asking, do you have somebody at the home or house that you really, really trust that we should be also interacting with? And just having that as a part of the first initial script has been a huge influence in us as a company being able to connect with the caregiver, because there's such a gap, as you just mentioned, in I can just think about like my grandmother who is about to turn 90. She's got a basic flip phone. And she loves people, loves to talk to folks, but has to have my mom, who is her caregiver on a day-to-day basis, be able to set up the calls and set up anything to do with that would be on the internet itself. That's a barrier that we understand. We just try to address it in the right way. Do we get 100% right? Not by any means, but between the actual inclusion of the question of who is the right person to talk to if it's not you, and secondly, here's an iPad if we really need you get you connected. That has been the two ways we've been able to try to come at this problem from the get-go. But great question. We haven't figured it out fully, but it's been a fun journey to try to tackle it.
Yeah, thank you. It is challenging. Yeah, I appreciate your efforts in that direction.
Great. Thank you, Nita. Great question. Do we have any more questions?
Hey, I had a quick question. First off, thank you for all of you guys for coming and speaking to us. I had a quick question for Shawn, someone who, in my first year of medical school here at UNC, I'm curious with your background, especially what you previously were talking about with military medicine and military healthcare. I was just wondering more as someone who could change, of course, but as someone who doesn't see a path in the military for me, I was wondering though what lessons you learned from the military that maybe could be applied to kind of general healthcare practices.
Honestly, it's the being open-minded and a teacher mindset. So one of the best things about the military is that we have this concept that there could be a fatality and you have to step up into the next role, which means that you're, as a provider, I had lots of physicians teaching me to do things that were well above my licensure and understanding the differences between that. So this teacher mindset just goes to everything, but it also opens up lines of communication. You're able to tap into, it's like networking, right? It's the importance of networking, except you now know who to go to in the hospital when you're having issues with certain things, but you also get this continuity of knowledge that when there is an emergency in the facility, you're able to apply that immediately. You don't have time to learn if somebody's coding actively. So being open to one, learning from people above you, people who are outside your specialty, but also being willing to teach people who are beneath you or outside your specialty. There may not be a reason for you to teach this person, but at some point that may benefit them and that may in turn save a life.
Thank you.
Great, Michael, terrific question. Thank you. All right, I am going to move on to our next moderated question. So for the panelists, what skills, abilities, and experiences do you use regularly, most often in your career? And were you surprised by any?
Negotiations every day. If you haven't taken that class yet, if you're currently a student and you haven't taken that class, make sure you do it. It is still one of the most impactful skills that I take from my experience at Keenan Flagler. And then the other one that it's always the soft skills, right? It's the communication piece, and especially in healthcare, I can't say it's more so than other industries because I'm really a healthcare person, but the ability to communicate at all different levels of an organization effectively has served me really well throughout my career. So as a consultant, being able to go into an ambulatory clinic that I'm assessing and sit down with the front desk person and get them to talk to me and understand what their workflows are and uncover what are the root causes of the issues in their day to day, and then being able to translate that up to the CEO of the health system into kind of strategic recommendations for his organization, and being able to kind of just switch back and forth effectively is critically important.
I'll piggyback off Audrey here. There's two classes that stand out in my undergrad at KFPS that the most. One was I've been trying to look it up. I cannot remember the title of it. It was management communications. I had no idea what I was getting into, but it was basically how do you present slides? I hate to say this for an Audrey because if I ever show a slide in front of her one day, she's gonna be grilling me as a consultant. But the ability to tell a story and do that just as Audrey just described, from a communication that can resonate from any level is critical. And a lot of times we're going to communicate on slides, and so that's just the one form that I would highly recommend leading into and learning how to do quickly on the fly. The other class that I found to be critical was Excel modeling. And man, I know that sounds really lame, but there is something that I think is universal across everybody's in our positions, which is somebody's going to send over a spreadsheet and you got to look at it and you got to understand how to manipulate data in a way that's going to both tell a story, but also like get you the answers that you want to get and communicate that up. I found that class to be revolutionary in my own learning and understanding what could be done. And I still go back to some of the hotkeys that I learned all the way back then. Yes, that's very lame to admit out loud, but it was the biggest influence of my overall what I do on a daily basis for the first few years coming out of college than anything else was that Excel class.
Yes, he said hotkeys, everyone.
Okay, all right, and at least it wasn't an acronym. Bad, yeah.
I think they both hit it on the head. So for me, the communication classes are great. Management communication, you're going to take it; it's a requirement. Uh, the storytelling is really important, but I also think the data analytics. So there's any data analytics class you can take. There's healthcare analytics is what I personally really loved, but there's also an Excel course taught by Training the Street. It taught me how to use Excel without a mouse, and that makes you feel very powerful because you are going to need to tell a story. You need to look behind the scenes and figure out where the problems are, but then you need to get data. When you're going to present to higher level leaders, you cannot go there and say, hey, I found a problem. You need to be able to show them there's a problem that exists. You've got data supporting it, and then you can go working towards a solution. So those are the classes that are going to build those skills that are going to make you ready for it.
Yeah, and I'll just add one more thing. For the women on the call, the research shows that women often shy away from the finances. And I encourage you to lean into them because you don't need to, that doesn't mean you need to spend all day, every day in the capital markets lab. That means you need to be able to effectively read a P&L. You need to know what EBITDA is. You need to know what ROI is. Just, I would call them fairly basic financial skills, but be literate in them and don't let it scare you. It really is critically important as you move into leadership to be able to have those conversations and to understand, to connect the dots between the brilliant ideas you have and the impact to the bottom line.
Terrific. These were wonderful skill sets, and I think you all explained those so well. Secondly, Audrey, 100%, and I encourage not only just women, but even like students that are kind of in the provider track, like MD, dental, nursing. A lot of the students I talk to are like, well, I don't need that. And I'm like, oh my goodness, if you're going to be a leader, you do. And it's really great because when you're looking at a clinic, if you know where the money's coming from, or how much things, cost or how the money gets there, you are going to have some power regardless of where you are in an organization. So thank you so much for that. We're pushing our finance courses, or accounting too. That's another one people shy away from, but I've heard is extraordinarily valuable. So I'm going to piggyback on that question. So when you look back, do you feel that there were any skill sets or any experiences that you wish you would have had, or skills that you wish you would have dug into a little bit more now that you are out in, the real world?
I'll kick this one off. Data visualization is also huge. So learning how to get the understanding is great. We went through a couple courses where they tried teaching us how to visualize the data, because you need this for the presentation point of it, right? At this point, you found the problem, you've found the data that supports it, you've made your presentation, but you need these slides that show it, because your key stakeholders only have a few seconds. So if you need to be able to have a clear, succinct slide that shows them why it's important and if they need to take action or not. So I really wish I'd done more with that, because just making charts takes time, and I would love it if I'd known how to make a faster chart, because I've definitely seen people who have like Tableau experts, and they're like, oh, this is super easy. We can bring up a chart of the United States in like 37 seconds. And I'm like, that sounds very helpful.
Tableau's for the young kids. Us old folks are stuck in Excel. No, learn how to use Tableau for sure.
Chase, any experiences or skill sets you wish you had gained in your education?
Yeah, I mentioned one earlier. I didn't know provider by the time I graduated, so that was a tough one to come out of college and not know terms of payer provider. No, and spoiler alert for the everybody's listening, we got these questions in advance, and so I've stared at this and like had a lot of like, oh my gosh, there's so much I could want to go back in, and it's also spurred like, oh, I really should like start taking these classes now, or revisit my education. There's two like really critical takeaways for me that I've come into thinking about this. The first is, uh, Audrey mentioned like broadly healthcare finance on the whole. I think that is probably one area that I would like to lean in more. And I think there's a criticality of understanding like what is the difference between private equity and venture capital? How does that influence how a company may act or react if you're trying to have a partnership with them, or the same thing of when you're looking at a health system's finances, like where are you going to pick up on what's key and critical from their publicly released statements? Like those are the elements that I am learning now, and I'm further along my career. I wish I'd learned that much earlier. I wish I'd learned that in college. So that's one area. And the second I would say is on the policy side of things. And so shout out to the NPH folks who are on the call. I wish I spent more time learning the skill set of reading and understanding policy, because I think it is ultimately the true driver of healthcare and everything we do. I'm a firm believer in there's that age-old statement that I can't remember who made, somebody in venture capital, that culture eats strategy for breakfast. I think in healthcare, it's policy eats everything, because of the implications of what we do on a day-to-day basis is solely driven by what CMS is going to require or not require, or bill or not bill. I mentioned CPT codes earlier. I know it's another acronym, but the thought concept of what is actually getting paid for is determined by healthcare policy. And that is something that I have shied away from traditionally, because I don't have the passion of really getting into deep discussion around CMS's stance or findings around a particular area. But I've also seen where that has completely accelerated folks for having the ability to distill, here's a policy that's coming down the tracks in 2 years, here's the business implications of that, and here's how we need to pivot from a strategy perspective as a company. And that's where I'm trying to get to in a lot of ways, but I would say that is an area that I wish I got to lean in more. I don't know if that's a class available on a day-to-day basis, but I would say if you have any electives that can switch over into policy land, 100% would recommend that.
Terrific. Wonderful suggestions. And I'd say that if you are interested in it, there is probably a class or a combination of classes in the university, again, between Keenan Flagler, Gilling, and many of the other schools. Many of the other schools are starting to pick up on the healthcare advantage and starting to offer classes that blend, again, when we talk about data or we talk about communication. You can look at the journalism school and they have some communications classes. So let's see here. So I am going to open up again for some questions from our audience. We're hearing a lot of interesting things, and you've got our panelists here to answer any questions you might have. All right, I have one here in the chat. So, hi, I have a question. I'm Savannah, an accelerated nursing student currently in clinic. I am very interested in leadership, and I'm wondering what next steps you recommend for new RNs to start building this skill set. It feels very overwhelming. Thank you, Savannah.
Yeah, I'm happy to take this one. No, sorry, Shawn, you are a nurse, so I should let you take it, but.
Yeah. How about you start and then I'll go
Okay.
after you.
Different perspectives, I'm sure. I mean, I just got excited about this because I think the opportunities for nurses these days in healthcare companies is broader than it ever has been before. In fact, I almost, what keeps me up at night a little bit is that there's too many opportunities for nurses to do other things and there won't be enough at the bedside, to be honest. But we love hiring nurses, and we hire them. One role, I'll just give you an example, is called a clinical performance partner. And so what these nurses do is, because they know how to communicate with physicians, they understand clinical workflows, they understand kind of the outcomes that result from certain clinical outcomes. We deploy them to go out to our practices and educate and promote things like office-based procedures, mammography, behavioral health screenings, like kind of those quality initiatives that are really important for our OBGYN providers. But the OBGYN providers are kind of heads down trying to just see as many patients as they can per day. These nurses are wonderful educators and partners to these physicians. So that's just one opportunity. And I would say, in terms of how do you get there, start taking leadership roles within your clinic, within your department. Look for quality improvement initiatives, projects that you can take on to kind of build your leadership skill set, and to have resume bullets to indicate that you're interested in doing things beyond, not that nothing wrong with taking care of patients, for sure, but if you have aspirations to do more in healthcare, to take on different opportunities in healthcare, there are always opportunities. I'm sure Shawn can speak to them as well, within your clinical environment.
Great. So I would tell you to hit the ball running. It's go talk to the nursing manager of your clinic and see. Quality improvement is great. There's tons of things they're looking for you to do. These unfortunately are always extra. These don't usually come with a lot of perks, but the experiences you build they do build great resume bullets, but they're going to help build you as a stronger nursing. You should also figure out what type of nurse you want to be. So there is bedside nursing, but if you want to be an NP, if you want to be a CRNA, there's a lot of upward mobility. There's advanced practice nursing. There's nurse educators. Nursing has a very broad field. So the sooner you figure out where you want to be, the sooner you can start plotting that and figuring out what leadership they're looking for. But step one, I would say talk to the nurse manager of your ward and say, hey, I'm open to doing things. I want to do more leadership stuff. What do you need help with? And I guarantee you they will have things. They'll be like, this is great. We love this. Because honestly, it's your shining stars who come through and want to help do things that really help drive change. And that benefits you. It benefits the board. It benefits the facility.
Terrific. Wonderful question, Savannah. Thank you. All right, Nita.
Hi again. I didn't introduce myself earlier, but yeah, I'm an orthodontist by training and currently doing my full-time MBA at UNC. My next question is about something very interesting. Audrey said, I mean, the organization is PE backed, and there tends to be some hesitancy on the part of clinicians sometimes. But I would love to know if you came across something surprising, something that challenged and gave you a wow moment. Okay, that they clinicians are not as opposed, or they find something good in PE backed organizations. Any moments of those kind that you came across? Thank you.
Yeah, well, we have 2,800 OBGYNs who I think don't think PE backed is all that is all that bad. I think, it does get a really bad rap, and there's reasons for that. I mean, there are organizations that have not treated physicians well, and I think the model really matters. And that's why I made a point to call out that we don't employ the physicians. They're not employees of the PE of the management company and or the PE group. They maintain their autonomy in terms of they're employed by their medical group. And so that means also they have the autonomy to make decisions on who they hire, how many nurses, how many MAs they have in their clinic. They own their bottom line. And so I think it is important. Not all PE-backed companies are created equally. And so there's also a lot of perks that come with being a PE-backed company. We're able to offer infuse capital into these practices that they wouldn't otherwise have access to. When they're hiring new OBGYNs or midwives, we're able to provide them funding to help support the salaries because it's a really competitive environment out there. And so oftentimes private practice aren't able to compete with hospitals in terms of residents offers for residents coming out of residency. So we're able to help support them with that. We're able to help them create ancillary services like laboratories, mammography, breast imaging centers, et cetera, that they wouldn't be able to fund on their own. And that is all, and that revenue actually goes back to the doctors, right? So I think there are certainly pros. Now, are there some cons? Of course. It is at the end of the day, it's about the bottom line. And sometimes, while I don't think it's every day by any means, or I wouldn't be in this space, there are situations where we have to say no to physicians because it's not approved by our sponsors. It's not something that, we are not a non-for-profit organization. So we do have to keep an eye on our profitability. At the same time, we are in women's health and we believe in women's health, and our mission is to improve women's health. And so it's a constant balancing act, but, we know very well that we wouldn't be anywhere without the physicians. And so we have to treat them well.
Yeah, thanks a lot.
Thanks for the question. And Vincent.
Can you guys hear me?
Yep.
Sweet. All right. First of all, thank you guys for coming out and being part of the panel. I really appreciate you guys for sharing your view on healthcare from a management perspective, because those skills and that kind of stuff is important to, I believe, all people, but in healthcare as well. I'm a pharmacy student, and I noticed that one of you talked about like a critical issue in the field, like talking about like you got one med and it has side effects and you prescribe a different med. I try to ask this with a lot of people who recognize this issue, like how do we as healthcare professionals hold ourselves accountable to make sure that patients get the right amount of healthcare that they need?
That's no small question. So
yeah. Vincent, thank you for asking this, and I think I think there's a hush that has gone over the crowd because there's not a clear answer. I will speak this very briefly from a non-clinical perspective, but also one that I've seen in my own life, but also and something we strive for at Thyme Care on a daily basis. One of the common issues in healthcare, but I think specifically is oncology, is that when a patient is referred to a specialist, in this case, an oncologist, and goes from the site of care being primarily their primary care provider to another doctor who's now their quarterback of care. You could see this in probably something like nephrology or their OBGYN in some cases. Audrey could definitely speak to that better than I can. There's oftentimes that is a excellent handoff, but there's sometimes that is not done in a very efficient manner, specifically about medications that are taken. The example that is prevalent in oncology is that if somebody is diabetic and then they receive oncological treatment, they will be prescribed a steroid. And that is awful for the outcomes of that diabetic, but the oncologists have no idea because they're not seeing what those actual labs are, and they just have no idea in general. They're just saying, "Yep, you get in this chemo, you need to get steroids." That's happened to me before. Like it happens. So I would say that there is ample opportunity in that primary care to specialist handoff that technology can serve and hopefully solve. That's something that we are focused on deeply. But there is an element of interconnectivity that is not there right now, and that's clear across the board. So my short answer is, like, if we can get that piece right, that's going to help lower some of the over medication to some degree, but we are still very, very far away from that. Time Care is trying to solve it, but we've got a long ways to go.
Again, very deep question. Shawn, go ahead.
Well, I'll also add that we don't also look at all of the determinants of health. We talked about like the social determinants of health. Like your weight plays a huge impact. There's a lot of extra medications people have. So teaching more people about proper healthcare is great. We give a lot of meds to solve problems that we don't necessarily, that maybe aren't appropriate. Also multidisciplinary rounds. So it's something the hospital does, I think, is phenomenal, and it's probably where Chase struggles with, is that there's no multidisciplinary team when you're going from physician to physician. But in the hospital, like especially in ICU settings, what you're going to find out is that you have a pharmacist, you have the nurse of the patient, you've got the physician. You usually have several physicians there, and they are all going over the plan of care for the patient. They're reviewing meds together to find out what's appropriate. You've got 6 to 7 eyes on a patient at the same time focused. And I think you need to figure a way where we can get more people in the room at the same time. So whether it's a quick Zoom call, but having them at the bedside, that's where you have your best outcomes, is they see which medications are appropriate, and they'll catch things like, hey, you can't give this person a steroid because, like, I don't think I appreciated the importance of a pharmacist at the bedside until these multi-D rounds where they're catching things like, you can't give them this antibiotic. It's going to interfere with this other medication that's keeping their heart going. Like, we need to switch it over to this. So multidisciplinary teams and really just working. It's teamwork, which sounds cheesy, but it really is what's going to solve things. We just don't like to do.
I noticed that throughout my, like, we're always being taught healthcare is a team and that whole thing. So
I do love the team word.
Yeah, because let's be honest, I mean, doctors aren't, there aren't enough doctors to go around and take care of our population. And so we have to figure out how to work as teams, and we have to let people work at the top of their license and, do everything. We just, that's just the reality of our current state.
But also, visit kudos for asking, and also I just want to emphasize the importance of pharmacists in that team, in the multiple, like that. It is so critical in what we do on a day-to-day basis, and I feel like I look up to all of our PharmDs that are on our team. So I just want to now. I've changed my career path. I want to be a PharmD in life because they're so much smarter than me. So as you are.
thank you, guys.
Thank you, Vincent, and thank you, panel, for answering quite a deep question right there, and having some really interesting answers that were very forward-thinking. I also popped in our IPEP at UNC. So that's our interdisciplinary education and practice. So if you haven't checked it out, any of the students, please do, because it's all about what our panelists just said. It's all about the team, interdisciplinary work. And right now you can start meeting people that are in different disciplines, pulling them into your projects, or just meeting them and talking about their perspectives to add a perspective to yours. All right, so we are getting close to 7 o'clock, so I am going to take the opportunity to ask our final question, because I feel that everybody knows that things are changing quickly in healthcare, in every single industry, every single part of every industry in healthcare. So I'd like to know from our panel, what do you see as the direction for your company, for industry, moving forward? And what excites you about the future of healthcare in general? So you guys can start anywhere.
Go for it.
Go first. As far as the future of healthcare, I'm excited to see what AI can do cautiously, but I'm hoping that we will use it appropriately for things. So for me, supply was a huge issue in the hospital. We have what's called Pyxis machines, if you're familiar. So they're medication dispensing machines, and they keep track of how many meds are on a floor, but they also have supply Pyxis machines. And at some of the facilities I had beautiful, modern supply Pyxis machines. They were gorgeous. But when you run out of things, some of the older systems don't have ways to be manually replenished. Like, I had a system that had these little tags. You'd take this, put on a magnetic board, and if you got it there on time, supply would bring up more stuff. Otherwise, you'd have to wait 12 hours for it to run again. It was a very inefficient system. So I'm hoping to see what we can use AI for, because there is a company, I forget what it's called, but they are doing something very similar where they're using AI cameras to look directly into supply bins to monitor the quantity of these things. So instead of relying on people, because nurses don't always push the counter button to move it up or down. So having cameras watch to find out when we're running out of things so we don't run out of crucial supplies in the facility.
Women's health is hot right now. It is kind of all over the place. It's like we've just discovered menopause here in the last couple of years. So there's just so much buzz about women's health. You can argue that, it's just been underemphasized for many years. I think it's just going to be about providing more coordinated, comprehensive care for women. I think it's right now care is so disjointed across our organization. It's, across our healthcare system, not organization, but, and the challenge among us all is to figure out how do we partner with payers, with other provider types, with different subspecialists, virtual care partners, et cetera, technology to improve women's care. I mean, it sounds grandiose, but that is the challenge before us. We know that the current system of just, go to this doctor, fee for service billing, get referred to the specialist, more fee for service billing is just not a sustainable long-term solution. It doesn't serve anyone well. It's not good for the cost of the care. It's not good for the women. So how do there's a lot of point solutions out there, but I firmly believe it's going to be the person who can knit all those together into something that is actually has a meaningful impact for women. I can't go so far as to say it'll be a one-stop solution, but at least the onus won't be on the patients themselves coordinating their care. A lot of that will be done for them. I'm sure that's a lot of what you guys are focused on at Thyme Care as well. I wish I knew better how we're going to get there, but at least I know where we need to be.
Co-sign everything Shawn said, co-sign everything Audrey said, 100%. I'll be really cheesy here. I'm really excited that UNC has a Center of Business of Health. This was not accessible when I was an undergrad, this type of format. It just gives me a lot of joy that we've got this right now at UNC. The fact that there is a new building being built on campus and there will be a space for folks that are healthcare focused. I just remember trying to figure out what I was going to do as a career, and looked around, and all of my classmates were just doing consulting or iBanking, and I was like, I don't want to do that at all. And yeah, this fires me up that we're doing this right now. Is it going to change healthcare forever? I hope. We're gonna make it try it that way. But in the meantime, like, just ecstatic. So shout out to the team, and excited to see where this whole thing leads us.
Terrific. And I just appreciate all of our panelists. And again, Chase, thank you for that, because this is important. These folks are important. You're learning from folks who are, just masters in their careers right now and have had the experiences that you will have. So I can't thank them enough for their time. The hour went so quickly. I was like, 7:01, how'd that happen? But again, thank you to our audience for joining tonight. The questions were wonderful and very insightful, as were the answers. So I cannot just, appreciate you all enough. Please join us for our next panel. And again, I hope everybody has a wonderful evening. Thanks again, and we'll see everybody soon. Have a good night.